Morning and welcome to the North Shore Outcomes Research Seminar and the third in our Health Equity Research Series. Today, we are honored to have Dr. Emily Gurley, who will be presenting her research on the spillover surveillance and One Health response, understanding emerging zoonotic threats in real time, and an opportunity to talk about, from a health equity perspective, our preparedness for future pandemics. We will also be joined by an expert panel, including Dr. Adjoa Inyani-Yeboah from Massachusetts General Hospital and Harvard Medical School, Tamika Crump, a leader at North Shore University Health System, and from Northwestern Feinberg School of Medicine, Dr. Claudia Hawkins. So I'd like to start off and introduce Rachel Brewington, who is the facilitator and my co-pilot throughout this seminar series. And my name is Sean David. I am the program director in translational science at North Shore with the Outcomes Research Network. I'd also like to take this time to thank everyone working on the front lines in the quest to advance health towards health equity across Chicagoland. And I'd like to thank the North Shore leadership and our entire team for sponsoring this event, which is also part of the University of Chicago Rush University Institute for Translational Medicine. Just a little bit of background about the Outcomes Research Network. It's structured to provide and catalyze research across North Shore and our CTSA academic communities towards outcomes research. And we hope that ultimately this work will inform community access to care that's effective, efficient, and equitable, enrich the practice of medicine, and support strategic clinical quality and operational decision-making. For our Health Equity Research Series, our objectives are to, number one, to advance health equity in our health systems through dissemination of world-class research and science, health equity in our communities, policy change to promote equitable healthcare and outcomes, and to advance translational science. And we'll have an opportunity with our expert panel to talk about the implications of this work for these three goals. We want to support the flourishing of clinical investigators, bring people together and promote team science. And we want to also bridge researchers to their peer communities across Chicagoland and beyond. Ultimately, we hope that this contributes to the larger cause of promoting outcomes research that improves patient and equitable population health outcomes for our communities. So I would like to hand over to Rachel, who will be sharing a brief Zoom orientation and also talk about how to claim continuing medical education credit for this event.
Thank you so much, Dr. David. Hello, everyone. To mark your attendance and claim CME for today's session, please text the SMS code to the number shown on the screen. The University of Chicago Pritzker School of Medicine designates this live activity for a maximum of 1.5 AMA PRA Category 1 credits. Physicians should claim only the credit that corresponds with the extent of their participation in the activity, and other healthcare professionals will receive a certificate of participation. The opportunity to claim credit will open at the start of today's seminar and will close after 30 days. Credit cannot be retroactively granted beyond a 30-day period. Therefore, it is important that you text in promptly after the seminar to successfully claim your credits. In today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on your screen. If you are on a computer, you can access this icon by hovering your mouse over the bottom of your Zoom screen. Please give special attention to the audience of your message before you submit it. As you can see, on the image to the right, you can choose to message either the panelists and speakers, this will include myself, or you can choose to message everyone on the webinar. Feel free to leave your questions and comments at any point during the presentation. If you are experiencing any technical difficulties, please let me know by messaging all panelists and I will assist you as best I can. I'll hand it back to Dr. David, who will now go over the agenda for the day.
Thank you, Rachel. So here's an overview of the agenda for the seminar. Following our introductions, we are going to be joined by our lecture from Dr. Gurley, which will run until about 11:40. Following that, we will have question and answers. for at least 10 minutes, depending on the duration of the presentation. And as Rachel mentioned, you can submit your questions as we go along in real time in the comments section. We will keep track of those and feed those to Dr. Gurley. After that, we will have the Incubator Hub expert panel discussion with Dr. Anyana Yeboah, Tamika Crump, and Dr. Hawkins. And that will run until 12:25, and then we'll close up with some remarks at the end and some information about evaluations and access to our YouTube channel for those who missed the lecture today, the seminar today. So now it is my honor to welcome our guest speaker today. Dr. Emily Gurley is an infectious disease epidemiologist at the Johns Hopkins Bloomberg School of Public Health. But she's a professor of the practice epidemiology, primary division of infectious disease epidemiology, international health joint appointments in the division of global disease epidemiology and control at Johns Hopkins University. And I understand that she has been doing incredible work in Bangladesh since 2003, and we're honored to have her present to us today. Dr. Gurley?
Hi, good morning, and thank you for the generous invitation to join all of you. So today I want to talk to you about, let's see, there we go, spillover surveillance and One Health response. And I'm going to make the argument that this is really the best chance we have of getting ahead of pandemics. And to start, I want to clarify what I mean by spillover and One Health. So when I say spillover, I mean an event, a new infection in a new host. So a spillover is when a pathogen from one species successfully infects a member of a different species. And almost all potential pathogens, particularly in wildlife or other animals, can't cross the species barrier and infect humans. It's actually a very rare trait. But among those that can, there's still relatively rare events in any given time and space. And this schematic is trying to show you why. So you have to have the reservoir host for that pathogen present in sufficient numbers and excreting that pathogen into the environment at a sufficiently high level so that a human's going to come into contact with that pathogen. And then if the pathogen can overcome all of our innate barriers to infection, a human can be infected. So that one, that one infection represents the stars aligning, as you can see here. And this schematic comes from really nice work from Raina Plowright, if you're interested in more of the references here. But they're rare in any given time and place because it's really represents, the stars aligning when a spillover occurs. And I'm going to talk primarily about spillovers into humans today, but a spillover could also be a pathogen, crossing a species barrier and infecting another animal. When I say One Health, I mean a holistic approach to thinking about, well, in my case, human health. I'm an infectious disease epidemiologist. And so I come at these problems from the perspective of public health and human health. When we think about spillovers or anything to do with emerging zoonotic infections, a One Health approach that understands and takes into account the inextricable link between human health and the health of other animal species, as well as the environment, is crucial. I really don't think we can solve spillovers or emerging zoonoses without this kind of thinking and without using this One Health approach. So that's what I'm going to talk to you about today. And I'm going to make two arguments. We'll see whether or not they're convincing, I guess, during the discussion. But the first argument I want to try to make is that surveillance for and investigations of spillovers are crucial for our ability to mitigate the risk of pandemics. And furthermore, I want to present to you what I would consider an ideal spillover detection and One Health investigation process. And we can think about all the reasons we don't do this, right? It's ideal, meaning that it's not, in some ways not feasible in all places at all times. But I do want to give you some examples from the work and lessons learned that we've done in Bangladesh related to Nipah virus, which I think show at least proof of concept, and that we can overcome some of these barriers and make progress. So let's think about SARS coronavirus 2 for a moment, and how this unfolded over time, and how it unfolded in terms of our understanding and knowledge of the event. So if you'll remember, sure you do, late December, early January, January 2020, there was this detection of a large cluster of cases of respiratory disease that was detected. The etiology was at first unknown. This is commonly called syndromic surveillance, right? There's someone who recognizes, well, there are a lot more cases of pneumonia than we would expect, or respiratory hospitalizations. Something's happening, right? There's this large cluster detection. And then very quickly, after that cluster was detected, and the pathogen was identified, we realized that, well, transmission was already happening beyond that locality where the first cluster was identified. So by the time we recognize it, it's already moved on. And then what happened next? Very quickly after that, it's a SARS-like coronavirus. Well, where's the bat? So let's look through freezers, let's look through genetic sequences. Let's try to identify the bat where this came from. We knew from the first SARS that bats may be the reservoir hosts, likely are the reservoir hosts. And so we start looking for bats and bat viruses that could be the culprit. And then finally we think about, well, how did this spillover happen? What happened so that humans became infected? What was the chain of events here? And obviously, there's been a lot of discussion about how this happened. The reality is, by the time the large clusters detected, the trail's already cold, and it's treated like an afterthought, right? We should keep looking to try to understand spillover and the first human infections, but the reality is we may just never know. And for me, this timeline of events in our recognition is particularly unsatisfying and very frustrating, because it's the same thing that we did for SARS, same set of events, same, they unfold in this certain way over time, but our recognition is still only once a large cluster is detected. The same is true for Nipah virus. When it was first detected, first we wait for a large cluster, and then at the end we start thinking about spillovers. The same is true for Ebola. Okay, different bat, but we first wait for this large cluster, and then we try to go back in time and understand. And I would argue to make the argument that this is wrong. We're never going to get ahead of the problem if we're just waiting around for the large clusters to make themselves easily seen. In public health, we talk about focus on primary prevention versus secondary prevention. And both are important, of course. We want to mitigate the negative impact on human health however we can. But public health prides itself on being focused on primary prevention. How do we prevent the disease from happening in the first place? You've probably seen multiple cartoonish type things trying to represent primary versus secondary infection. This is a classic one where you have, people drowning, being pulled out of the river, and someone at the top trying to working on primary prevention is trying to prevent people from falling in the river. I would argue that therapeutics and vaccines, which are important and have been a huge focus during this pandemic, and even for preparing for the next pandemic, right? We're thinking a lot about how to make therapeutics and vaccines that could be quickly deployed if we see this large cluster of cases in the future. I would argue that those efforts are secondary prevention. And when we think about pandemics and primary prevention, really what we should be trying to do is prevent spillovers. And if I asked you, how do we prevent spillovers? Well, you probably don't know, and there's a good reason for that. Unless we study them, we can't figure out how to prevent them. And so that's one reason why I would argue that we really have to focus on finding spillovers so we can understand how they happen, which will then lead us to solutions for prevention. So again, why spillovers as the first target? And I'm sure, like me, many of you have been thinking about what could we have done differently to prevent the COVID-19 pandemic? What can we be doing differently going forward? And there are a lot of ideas about this and other options for pandemic risk mitigation. And so I think it's worthwhile just reviewing what some of those are. First, we can try to find pathogens in wildlife that could be potential threats. There have been a lot of efforts to do this, many years of efforts, even before COVID-19. USAID spent a lot of money on a project called PREDICT, which aimed to catalog new pathogens in wildlife, key wildlife species, in areas deemed at high risk for spillover. And the difficulty is, if you go looking for new pathogens, of course you're going to find them because we've never explored this space. And I've seen an estimate that more than 99% of all viruses remain undiscovered. So if you go looking for viruses, you're going to find them. But what do they mean? And this work got a lot of criticism because, all right, maybe we have a genetic sequence, but what does that mean from a public health perspective? How do we know what to do with that? One answer to that is, well, we could do a lot of laboratory work to see if this pathogen is pathogenic to humans, or if this potential pathogen is pathogenic to humans, in the lab or other mammals. That's true. That's very resource intensive and also puts us into kind of a grayer area around gain of function research. And I think we should be wary of that. So to me, this approach has a lot of limitations. Another option is we could detect outbreaks faster. So when there's that cluster, let's make sure we find it faster so that we can try to stop a pandemic from happening. The problem is, by the time we find those big clusters, if that's what we're waiting to see, it's often the case that transmission has already moved beyond that cluster before we find it. How fast would we really need to be to prevent that spread if we're just waiting for the cluster to occur? For COVID-19, we saw that we were faster than ever actually in detecting new introductions of COVID into countries once we recognized that spread was happening. So we were really fast in finding those new introductions. That still didn't allow us to stop spread within those new countries. So again, I'm not sure that worked for us. Finally, development of vaccines. And again, I think this is secondary prevention. It's important to do. It's worth investing in, but it's unlikely that we're going to deploy vaccines fast enough to stop a pandemic from taking place. Okay, so what advantages does a spillover focused effort give us? What does it give us if we look at spillovers? First, it gives us actionable data from a public health perspective. So if a human has been infected, something's already happened, right? Those stars have aligned. We don't have to wonder, could this pathogen infect people? We already know it has. So then we can take steps, jump ahead and focus on that pathogen right away. From a pure numbers game, right? if you think about from the perspective of the pathogen, each spillover is an opportunity for evolution. If you'll permit a soccer analogy, each spillover is a shot on goal to try to develop a new niche, a new host, to expand yourself in the world. So each spillover is important from the perspective of the pathogen. Each spillover is an opportunity to learn. So if we're tracking spillovers in real time, we can understand how, why, how often they happen. And that can lead us to prevention. As I mentioned here. And finally, a common difficulty with convincing donors to fund outbreak prevention efforts is that, well, if you've prevented an outbreak, how would you ever know? Donors want to see that their funds are used and you have some measurable outcome to show that it's working. Well, spillovers are much more common than outbreaks. So if we're focused on those, I think then we can start to build an evidence case for prevention in a way that outbreaks just don't allow us to do. So I'm going to talk to you now about some of the Nipah work I did during my time in Bangladesh. I spent most of my career there and was the director of the Emerging Infections Program at a place called the International, the ICDDRB, which is a Health and Population Research Institute in Dhaka, Bangladesh. And it was a really unique place. We were a truly One Health multidisciplinary team. And just in this photo, we have anthropologists, microbiologists, wildlife veterinarians, physicians, epidemiologists, health economists. And we were supported by the US CDC to provide support to the government of Bangladesh for both spillover surveillance and One Health investigation and research. We've been working on Nipah there, since I started there in 2003, and even before, just before I started, they had retrospectively found the first Nipah outbreaks in Bangladesh that were, I think, identified in 2001 and 2003. And in 2015, Nipah made a list, WHO made a list of the biggest, baddest pathogens that we should focus on. And Nipah made that list along with other SARS coronaviruses and Ebola. And it made the list because it has some key traits that make us, motivate us, let's say, to take some action. So it's a bat-borne pathogen. It can infect humans. And importantly, it can cause human-to-human transmission after the spillover event. It causes at least 40% mortality. In Bangladesh, the mortality's been closer to 75% overall. And we have no licensed treatments or vaccines beyond supportive care, although I would say the protocols for supportive care in human infections are really lacking and poorly developed. The basic reproductive number, which I assume you're familiar with now, is less than 1, obviously, or else you'd all know a lot more about Nipah than you do now. But for specific demographics, adult males who have difficulty breathing during their illness, the reproductive number is about 1. So we see differences by age and sex that can drive outbreak size. And so it's something we don't understand, but is concerning for broader spread. And so WHO put Nipah on, highlighted Nipah, why we should work on it. And there has been some movement in developing target product profiles for vaccines and diagnostics. This is a photo of most people in the world who work on Nipah. It's not a big group. We met in Singapore in December 2019 to commemorate 20 years since Nipah was discovered and review our progress and where we were. Here we are, blissfully unaware of the pandemic that's starting around us. So let me talk to you a bit now about what I think is an ideal approach for understanding spillovers. And I think we should start with spillover surveillance widespread in areas where we suspect spillovers could occur. I think it should be clinic-based because that's the most efficient. For most people who are infected with novel pathogens, there's going to be a febrile illness. And so I think clinicians here are on the front line, and we should set up surveillance systems to try to identify potential spillovers. Of course, the number of patients that represents is just overwhelming, right? We can't investigate every single patient, and there are competing interests here with other clinic priorities, other public health priorities. So one thing we can do to try to narrow the list of patients that we focus on is to look at those with risky exposures. So for example, you screen every patient admitted for a history of contact with wild animals. Are they a butcher? Are they a veterinarian? Are they a lab worker? Are they a healthcare worker? So things that could give us a sense that, all right, there's something going on here, or this patient deserves maybe a closer look. Once you identify that risk of patients that deserve a closer look, we need a way to rapidly screen for known and unknown pathogenic threats. Right now, we do not have this. And this is a major bottleneck and reason why we don't do this surveillance more broadly. For Nipah, we do have some rapid screening tools, and I'll tell you a bit more about what we do, but this is an area where I think we could improve. So through all that, once we identify a spillover, that to me represents, a smoke detector. There's an alarm going off. We should take action. As I mentioned to you, our work on Nipah in Bangladesh is a longstanding effort between our research organization, the U.S. Centers for Disease Control and Prevention, and the government of Bangladesh, the Institute for Epidemiology, Disease Control and Research, which is akin to the U.S. CDC in terms of their function and role. And I think, this focus on spillovers accompanied with a One Health investigation, I think it works really well when you bring together public health practitioners, clinical practitioners, and researchers. Everyone has a role to play. And if all these groups are working together, that's when you can really, bring to fruition the promise of these approaches. We started spillover surveillance in Bangladesh in 2006. We started at 3 tertiary care hospitals. This is a map of Bangladesh, and the black crosses represent the hospitals where we started surveillance. We had year-round surveillance for clusters of infection, but from December through March, we tested every patient who presented with signs and symptoms compatible with meningoencephalitis. So that was the primary clinical presentation in Bangladesh for Nipah virus. And so every patient gets tested. We collect blood, saliva, and cerebrospinal fluid from those patients. The oral swabs with saliva on them undergo real-time PCR. And that's really what we use for our One Health investigations. But we also confirm infections using antibodies, looking for antibodies in sera. The antibody tests are a bit finicky and they take more time, so they're not good for real-time response, but we often find patients with antibodies, even though we didn't detect any viral RNA in their oral swab. Around these sites, you can see some of the spillovers. The red dots are spillovers that we've detected through the surveillance. And those spillovers are way more common than outbreaks. This isn't a complete map of all the spillovers we've detected. It's more than twice this number now. But just on the 10-year period between 2001 and 2011, we detected more than 50 spillovers of Nipah virus into humans. During that same time, if we were waiting just to see a larger outbreak, we would have detected only 8. So that gives you a sense of what we're missing if we're not actively looking for those spillovers. Almost all the spillovers are isolated. They don't infect anybody else, but each one's an opportunity to learn how that spillover happened and also to prevent onward transmission, because we don't know who's going to transmit and who isn't. So what do we do when that spillover is detected? I would argue the best thing we can do is the One Health investigation. And I want to talk through some of those components now. So the first is a genetic characterization of the pathogen, right? We can characterize what's infected the human and also look for that pathogen in other animals. The clinical presentation, describing that in detail, including post-mortem exams, are really very important when spillovers are detected, because that helps us understand, the pathologic process, how this pathogen is causing disease, what ultimately was the cause of death. It can help us understand a bit more about how transmission between people might be happening. Where do we identify the virus in the body, and what's the natural history of the infection. But importantly, we also have to get out of the lab and the clinic. That's not sufficient for understanding spillovers. We have to go back to the community. So where does this person live? We need to identify all their contacts. We need to see if maybe they were in contact with a different patient. Are they already a link in a transmission chain, or are they a true spillover case? We need to understand their recent exposures prior to their illness. We should enroll controls. So case control studies are the most commonly used for epidemiologic investigations of outbreaks and spillovers, because it's a very flexible study design. So if you understand for the spillover case, their recent exposures, you need to understand from a random sample of people in their community, what kind of exposures did they have during that same time period? And within any outbreak, individual outbreak, your statistical power to see differences between cases and controls is limited, but you can accumulate case and control data over time to try to understand from a statistical perspective which exposures are associated with spillovers. We should be doing contact tracing, of course, I already mentioned that, and then sampling of other animals. So wildlife in the area, did the case have contact with other animals? What type of contact? And have any of those animals demonstrated illness? Are they shedding that pathogen? What's going on in the field at the time of the spillover? And I would propose that if the spillover detected is like a smoke alarm telling us that we should pay attention and investigate, the One Health investigation is the symphony that comes next. So it's bringing together all of these perspectives and areas of expertise to try to solve the problem. And then, of course, we update, right? So whatever we find in the One Health investigation should update our surveillance. Did we find a new exposure that might help us understand transmission? Well, that could go in the risky exposures questionnaire to update that. What about the genetic sequence? Is there something that we're routinely missing in our screening? Well, we can update that too. So this should always be a learning loop. I'm going to tell you now a little bit about our One Health team and give you some examples of things we've learned with this One Health approach. So in studying Nipah, right, we have epidemiologists, anthropologists, physicians, virologists, ecologists, and veterinarians. And let me give you some examples of what we've been able to do. So, epidemiologists describe things in terms of person, place, and time. So the map on the left shows you, this is about 14 years of Nipah case investigations in Bangladesh. And we're describing the intensity of those cases by geography on the left. On the right, because we've had systematic surveillance with the same surveillance effort year after year, we can plot the number of spillovers by year and come up with hypotheses about what's driving this process. So you can see here between 2009 and 2010, there was a big increase in spillover events. And then after a few years, it came back down significantly. why. We still don't know, but this allows us to begin to develop hypotheses about what's happening in the environment and with reservoir hosts and human behavior that could be driving spillover patterns. Importantly, we can also track the reproductive number over time. And I mentioned to you that our surveillance started in 2006. So really that's the only time points we can interpret here. But we do see variation in person-to-person transmission potential, it seems, over time. The confidence intervals are really large, agree, but there could be something here that, again, can give us a hypothesis about what's driving risk of person-to-person transmission year over year. And again, that would be really important to understand in terms of pandemic mitigation. Through contact tracing, we were also able to describe the offspring distribution. So how many cases on average does each Nipah case infect? And we learned that only about 10% of cases, 9 in this case series, transmits to anybody else. So almost all Nipah cases lead to 0 further cases. Almost all Nipah cases had a median of 17 close contacts during their illness. There were no differences between cases that transmitted to another patient and cases that didn't in terms of the number of contacts. That's not what we were expecting to see, but suggests that there might be something that's driving transmission beyond just the number of contacts, right? It could be something about the biology of the case patient themselves. Caregivers and spouses were at highest risk for transmission. And so that's important for us to understand in terms of prevention. One more point on the epidemiology. So this map comes from an investigation we did in 2005, where we used a case control study approach and showed that Nipah cases, were 7.9 times more likely to have reported drinking raw date palm sap than controls. And this was an exposure that was significantly associated with the outcome. And in this map, you can see the red dots that represent the cases that we identified in this outbreak. And you can see that many of them lie along this road, also in orange. What we learned is that a few days before the outbreak, someone was selling raw date palm sap house to house along this road. And the cases that we identified on that road had all purchased sap, likely from the same sap vendor, in the days before they became sick. So this investigation was really our smoking gun, where we understood finally how Nipah was being transmitted from bats to people in Bangladesh. And it was through this sap that's a shared food source for bats and people. So then we turn to our anthropologists to help us provide context. What is date palm sap? Really, how is it farmed? And here's a picture of a date palm tree. You can see a pot hanging in the tree, a clay pot. And the pot's hung overnight. The sap drips from the tree into a tap that goes into the pot. Sap collectors collect the sap in the wintertime, and that aligns with when we see spillovers, primarily in the winter. And they report that fruit bats can be a nuisance because they drink the sap, which reduces the amount they can sell. They defecate into the sap and occasionally drown in the pot. And so they were also interested in keeping bats out beyond just, our interests in preventing Nipah. Anthropologists were really crucial in our ability to communicate with communities during outbreaks as well. So one of the first big outbreaks investigations that we worked on in 2004, we used what we knew about transmission to create messages for the community. We told them, this is a bat-borne pathogen. This is how we think humans are infected. It can be spread from person to person, so please take these steps to prevent transmission to your loved ones. And we did what we thought was our best at providing those messages. An anthropological team went back some months after the outbreak to talk to the community about what they had understood in our prevention messages. And the results weren't good. Community members not only didn't believe what we said about the transmission pathways, they didn't find our narrative credible. They also were very distrustful and believed that the clinicians were intentionally killing patients to end the outbreak. So they didn't even want to bring their patients to hospital. So we said, well, we got it wrong. Let's keep working on this. We've got to find a way to connect with people in outbreaks. And this paper represents the culmination of those discussions, where we were finally able to bridge the communication gap with communities. And the paper title is even, it's not just what you say, it's how you say it. This is a photo of bats coming to drink sap with the pot, nearby the pot at night. And we realized just how powerful photos can be when we're talking to people about zoonotic transmission. And here's a quote I'll share with you. So someone in one of these outbreaks told us, okay, the illness, which we considered Asmani Bala, which means a crisis or hard time given by God, you call it a virus. So we have to agree that the virus is the crisis and the crisis is the virus, right? So we're using different words, but we're meaning the same thing. And this is how we were able to make some links and engage in discussions around prevention. The anthropological approaches also gave us hints about how we can keep bats out. So we relied heavily on them to understand what was already being used by sap collectors to keep bats out. There were already some methods being used that we could promote. And of course, we had a lot of behavior change and prevention messages that they helped us develop. Okay, clinical descriptions have also been really important. So this was a chest radiograph from an early outbreak in Bangladesh, where we were able to show just the real involvement of the respiratory system and infection, which had been described a bit before, but really not to this extent. We're limited by our ability to investigate clinically in Bangladesh because of concerns around infection control. You don't want to move a patient and potentially expose more people to that patient. And patients also typically present towards the end of their illness. So that's another barrier. Our virologists have been able to look at the variation in the sequences that we've identified, and when they diverged from other lineages that have been identified in other parts of Asia, including Malaysia and Singapore. Ecologists help us understand. So here's another picture of a bat licking the sap coming out of the tree. They've helped us understand, how bats get in and some of the bat behavior associated with Nipah transmission. And we've also, started doing animal sampling around spillovers. So this is a map of all the spillovers we've investigated with additional animal sampling. And we sample bats, where we found a lot of bats shedding Nipah viruses. That shows you on the left. If we're able to get there quickly, even within 20 days of when the spillover happens, we can still find bats shedding. And that's really important. We can also find other livestock that are seropositive, meaning that there have been spillovers into other species. Soon, we're hoping to start a new project in Bangladesh to look at spillovers. This lovely figure was made by my postdoc, Cliff McKee. These are all the different pathways of transmission we want to investigate in rural Bangladesh. Looking for spillovers with the aim towards preventing them. And we're looking, across multiple species here. So a few parting thoughts. I think focusing on spillovers is the best chance we have for pandemic prevention. And our experience in Bangladesh has showed us that it's possible and that we gain invaluable insights by doing that. I think this can't be a niche field, right? This has to be something that involves multiple disciplines, and everyone needs to be thinking about how they fit into spillover surveillance and the One Health investigations. How do we integrate One Health into our public health practice and pandemic prevention? So I look forward to chatting more with all of you. Thanks.
Dr. Gurley, thank you very much. I'm going to pass this over to Rachel for a Q&A.
All right, thank you so much. And thank you very much, Dr. Gurley. We will take some questions at this time. We'll probably need to we might not be able to take all of them, but let's start with our first question. Okay. Are Nipah virus spillovers predominantly airborne, or can that virus be transmitted to humans through bat or other animal bites like rabies?
So great question. We've investigated all the potential ways it could be transmitted to people at every spillover we've identified in Bangladesh. So we're in the hundreds now. And for every spillover for the case, as well as a set of controls, we ask about things like physical contact with bats, getting a bat bite, living underneath a bat roost, which is very, very common in Bangladesh. Bats are ubiquitous across the landscape. Did you eat a piece of fruit off the ground that could have bat secretions on it? Did you drink date palm sap? And consistently what we find is the only exposure associated with being a spillover case is drinking date palm sap. That's it. Which I think is a real, it's a great lesson learned, because it tells us that among all the potential exposures that people have and could have to the virus, there's really that one pathway that leads to transmission, which is actually a good thing. Then that means we can focus in on that pathway to prevent the spillovers.
Okay, thank you.
Thank you. And I have one more quick question before we go to the panel. So, how are the 9% of transmissions between people? How does that happen? Is it airborne? Is it intimate contact? And is there something equivalent to a spike protein that could mutate and make it more infectious?
I'll start with the last one first. I don't think we're smart enough to know what genetic changes would confer increased transmissibility for Nipah. So I think that's an open question. Right now, transmission does happen typically with prolonged contact. We do have some examples of transmission that seem to be more, distant exposure, no known physical contact with a patient, yet somehow they were infected. Those are always difficult to interpret, but there's variation. There's a lot of variation year to year. We do have examples of post-mortem transmission similar to Ebola. So the person who washed the body prior to burial, for example. But the reality is, in the current epidemiology, it's not a pandemic risk, right? Because the R0's less than 1. You may have outbreaks, but it's never going to get that big. If we knew for sure it was never going to change in terms of its transmissibility, I would focus my time on other things. But the problem is we don't know that. And we don't know enough to know, what increases the risk of that kind of spread. So that's why we continue to think about it.
Thank you very much. So with that, Rachel, should we segue to the expert panel?
Sure.
Thank you so much. So for a really brilliant lecture, Dr. Gurley, and I'd like to introduce our expert panel. Start off with Dr. Ijoa Anyani-Yeboah, who is a gastroenterologist at Mass General Hospital and an instructor in medicine at Harvard Medical School, who has experience doing health equity research in COVID-19 epidemic, but also in other contexts. Tamika Crump, who is a practice manager for the Community Health Center at North Shore and a health equity advocate in our health system and community, and Dr. Claudia Hawkins, who is director of the Robert J. Havey, MD, Institute for Global Health and the Center for Global Communicable and Emerging Infectious Diseases, and she's an associate professor of Medicine in ID at Northwestern. So welcome panel, and I'd like to move on to the next slide. So we just watched a really intriguing lecture about the Nipah virus, its epidemiology, spillover events, and the question that comes up to me is how public health was caught in its back foot with COVID-19, and really from a health equity perspective, what are the implications of if Nipah virus became endemic health equity in our health systems? How can we prepare to avoid some of the mistakes in access, treatment, and vaccinations that we've seen? So to the panel.
So I can get started with that. Thank you so much for such a wonderful talk, Dr. Gurley. I learned a lot about Nipah virus. But it's interesting because I think if Nipah virus, were to hit the US, we would see something very similar to what we saw in COVID-19, where some populations were hit harder than others. I think one thing that we learned in COVID-19 is it kind of pulled back the curtain on where the disparities were. And so I think if we were to see something like that, we would be able to mobilize quickly. That being said, I don't think we would be able to prevent what happened again, because in order to do that, we need to address the inequities that we see upstream in the social determinants, which we have not done. And those same inequities are what underlie many disparities, and COVID-19 was just one thing we saw. And so I think until we look upstream, if something like Nipah virus were to come to the US, we would see the same effects that we saw in COVID-19.
Thank you. Really, yeah. Tamika, your thoughts, we talked about in our health system, are we ready for the next pandemic, and what have we learned?
Absolutely not. I'm here at the Community Health Center, and here at the Community Health Center, we see underserved patients. So what that means is they're uninsured, so they have limited access. These patients are not able to get to their doctor's appointments on time, because of transportation. They don't have access to schedule appointments online. They have very limited access to communicate with their physicians, just calling, making appointments, the extended wait time, which causes them to just give up. So there is a lot of work to do with the underserved community. Yeah, so we are not prepared.
Thank you. Dr. Hawkins.
Yeah, I would absolutely agree. I mean, we're certainly not prepared. We weren't prepared this time, and we should have been based on our experiences with outbreaks in the past. I will say, just to go back to the speaker, what a great presentation, a great example of how we can and are able to sort of really get at some of the root causes of some of these pandemics or these outbreaks of infectious diseases. And I think it's fortunate in Bangladesh at least, where you've had sort of smaller outbreaks and been able to do some really great community research and involve the community in that research, as well as mitigation methods. And I think, we cannot do that here very successfully. And I think that's where we've got to learn to be able to do something like that very successfully in larger systems, with bringing lots of people together across healthcare providers, systems, everything, policy, government, you name it. And I think taking some of those lessons learned from that presentation would be, just excellent examples of what we could do for our next pandemic.
Thank you. Thank you. Great point. Well, I think that segues into our next discussion question, which is how do we prepare to move towards health equity with a community-centric approach? How do we engage the community early and be better prepared for the next pandemic, whether it is another COVID wave or another virus, bat-borne virus like Nipah? Thoughts about from recent experience?
I think one thing that we did in COVID that we kind of learned later was meeting people where they are. And I think that's one thing. I think there's a lot of things that we can do, but I think that's one thing that was really important. I think when we started off in the pandemic and we, looked at testing sites and vaccination sites and so forth, there were some, neighborhoods and communities where we would see testing sites and others where we wouldn't. And we actually, at least in Boston, had a map of where sites were located, and you could see the disparities. And so I think for the next pandemic, that's definitely something that's going to be important in terms of, one, meeting people where they are, and two, making sure that everybody has access, whether it's testing, treatment, vaccinations, and that we're getting those things to people where they are.
Thank you. Do you think that health systems and public health adapted and learned to better be able to meet people where they were towards the rest of the pandemic?
So I think so. And I think we mobilized very quickly. We definitely learned a lot. I think it took time. It took us seeing these horrible disparities for us to take action. And so I think in the future, we would probably be hopefully quicker with what we've learned, at least through COVID. But I think we would still see the same disparities because the underlying inequities still exist. And until we rectify those, we're not going to see any difference in the next pandemic.
Thank you. Well, it occurs to me that the cities represented, Boston, Baltimore, and Chicago, certainly have a lot of segmentation in terms of access and communities without the same level of resources. And looking to the future, how to better engage early these communities to be part of the One Health system is something I'm very interested in, thoughts about how to do that, because whether it's this or the non-communicable diseases that explain most of these health equity longevity gaps, love to hear your thoughts about that. Also, in terms of policy change needed to enable that to happen, to support that kind of work.
I mean, I'd like to just make a comment about disparities, and I think made a really good point about access being one of the main drivers of disparities. But I think that trust in healthcare systems is a huge driver of disparities in Bangladesh, in Baltimore. Here, sometimes it's difficult to convince someone to take, a course of therapy for TB, right? So I would argue that, building trust with communities and being seen as a credible source of information and partner in health has to happen way before any pandemic happens, because that's a really difficult environment to build trust. You've got to try to work for it so that you start with it. But it's difficult to do, and it takes a lot of humility, I would say.
Absolutely, Dr. Gurley. Especially here at the Community Health Center, we have mostly Black and Hispanic patients, and they want to see providers that look like them. That's a way to start to build that trust. Even, with leadership and the clinicians, once we get, more brown faces, then it'll be better to reach the underserved communities that has that more so of a Black population. So there is definitely work to do.
Yeah, and we talked to Nika about the digital divide, and the test results go into MyChart, smartphones, and that doesn't necessarily always get the information gets communicated to the people, right?
Yep, the limited access. These patients don't have smartphones. They're not able to communicate with their providers on North Shore Connect. They're not available to scan the QR codes. It's very hard for them, and that's why a lot of these patients, it's hard for them to have that opportunity to attain, their full health potential.
So thank you. And moving on to the next discussion question, policy change to promote equitable care and outcomes. And policy could be anything from health systems policy to legislation to better support community-based outreach and partnerships. So I think you described a lot of the barriers that persist. What's your sense of where we need to go to really build that trust, to really build that system that we should have? I suppose if you had the ability to have multi-billion-dollar legislation, what do we need to do this beyond the Cures Act and things like that?
So I can sort of answer on from my side. I mean, I think it's better distribution, right, of funds, whether it's for programs or research or whatever, in terms of trying to address these, outbreaks or any health condition, and a more fairer distribution when it comes to at least funding. And then, for that in turn sort of translates into policy changes as well. I mean, usually where the money goes is where the research goes and informs the policy. But I think just a more sort of fairer approach to everything in terms of, where the funds for these programs are going, for sure.
I'll make a comment on a global scale about this. One of the reasons why spillover surveillance isn't prioritized or done more widely is because it falls under the purview of public health surveillance, which typically is funded by governments and public health jurisdictions. And governments in places like Bangladesh, their primary objective, rightly so, is to use their surveillance funds for diseases that cause the greatest burden of disease, where they're going to try to reduce deaths and suffering in their people. So spillover surveillance is really niche, right? Bangladesh maybe causes a few cases a year. It's not going to compete in terms of burden for their other priorities. And so why should they spend the money on spillover surveillance? I would argue that spillover surveillance is not a local public health burden issue. It's a global risk issue. And the burden of financing to reduce a global risk should be global. So I think we have to get out of the paradigm of assuming that each individual country should be the one looking for spillovers to prevent a global risk. I think the global health community needs to assume that responsibility.
And the approach communities takes a lot of investment, time, people, building networks, earning trust over time. And do you see that this is a policy opportunity to better invest in that? For example, we have community health centers, FQHCs across the country that were supposed to help to bridge these gaps, but have left many gaps. How do we do that as a system, in addition to the public health, and properly integrate that with primary care?
In global health, the way this is often done is through community health workers. So it's not enough to have just a clinic nearby, but you have people integrated within communities, providing health services, not just there's a place closer to you where you can get this care, but who needs that care? How do you get people to the care they need? How do you help people understand what care they need? In our system, how do you help people fill out the forms they need to get that care? The elderly have, severe restrictions to access often because of those logistical barriers. Bringing it even further down into communities. And those programs globally are very successful, and we haven't really embraced them here. But I think we could do more of that. Yeah, even during the pandemic, right? It was so slow to happen, sadly. And we need other disciplines, right? Physicians and epidemiologists are just a part of who we need to engage.
Yeah, and I would agree. I mean, we need very many other groups of, often these responses, especially how I saw the COVID pandemic response, was very limited to sort of medics, right? And we need, it's very important to have perspectives as other people across, very many different social, ethnic, and gender strata, just to really inform on how we're thinking, how we're responding, and what programs are the most important.
Absolutely. Well, there's some great examples of people who have done that very carefully the right way over decades and have built those systems. But that community of solution approach seems to be isolated, fragmented, and not nationwide. So this remains a challenge to figure out how to support this, even when it's not flashy and trendy. So moving on to the next question is, what are the real implications for advancing translational science, but also what are the research gaps we need to explore? It sounds like there's a sociome of social determinants of health to better understand, but then we've also learned a lot about the lack of trust in communities, and we know a lot of things that are broken that we need to fix. But where would you like to see the science go so we're better prepared for the next pandemic? Big questions.
I'd like us to change the type of science we do to prevent pandemics. I'm still advocating for prevention, and because I think there is a lot going on about mitigation, and it's all good. We should, it's all a good use of time, but I'm not convinced that those mitigation measures are going to be, are going to give us ultimately, what we want. And we know that we're not getting rid of inequities anytime soon. So, even if we have new great vaccines, they're still going to be, restricted to certain populations first. High income countries are going to get them first, no matter what we do. What are we doing to prevent the pandemics? And I think there's very few people talking about that. So I'll just make my voice heard one more time on preventing spillovers to prevent pandemics, and leave it at that.
You're absolutely preaching to the choir. I'm a primary care physician, and this is so important to get. It doesn't always get the excitement behind it that it needs. But primordial prevention in this case would be going upstream even from the spillover events, isn't that right, to dealing with inequities, but also what kind of research in that primary prevention space do you think needs to happen next?
So
yeah, go ahead, Claudia. Please.
No, I was just going to sort of add what kind of research in the primary prevention. So I mean, I think what we're missing with the research is that we have too much. COVID is a good example of this. It's too much emphasis on sort of medical comorbidities that we're putting people at risk, for instance. And we really need to do better with our research in terms of measuring the often unavailable data that we just say is unavailable or unmeasured, and those really important determinants that obviously tell us who's at risk and can help inform policy. And those societal factors, environmental factors, access to care, all sorts of data that we often sort of ignore, and I think is really important to the scientific field to help understand the disparities and why we haven't got an equitable response. And then on top of that, the actual research itself, that's just the research itself, but then you've got research teams, I think, that need to be much more diverse. And the research needs to engage people who it matters most to. The research needs to be targeted at those who are faring the worst with these pandemics, or who we know are going to fare the worst the next pandemic that comes along. And that is having a good research, a valid and relevant research question, a team that can adequately address and do that research with the communities and involve the communities as well in that research process.
Thank you. Tamika, your thoughts about what do we need to learn in our health systems to better prepare? I mean, to meet patients where they are. Do you think we need to be more mobile, to go out in mobile vans and have health fairs, or to just learn from people what works and what needs to happen on the social determinant side?
Absolutely. We definitely need more staff. Yes, it would be nice to go out into the community and, take our nurses and physicians out to do like pop-up blood pressure checks. But what's going on in our clinics? Like, we're really short-staffed. Team members are overworked. Here at the Community Health Center, patients are here for 2 hours because this is a training clinic, for our residents, right? And then, a lot of our patients, have language barriers, that can be a 2-hour conversation with our social workers, which it makes it very hard for patients, to show up for their appointments because of the long wait times. So I think staffing, would help a lot.
Yeah, and we're only going to learn about those things by talking to people who are doing that work on the front line. So that's an important area of research upstream. Any other thoughts about where you would like the science to go for preparedness? Good. Okay, so if we could, I think what I'd like to say is with this, thank you so much for the panel. This has really highlighted in a very sobering way how much we, although we may have learned something from the last pandemic about persistent health disparities, that we're still not quite ready for the next one. I think we'd be in the same situation, but hopefully with enlightenment, people can begin to have community-based approaches to better prepare. And it sounds like we need much more public investment in really training an army of community health workers who, with diverse teams, to begin to take on that science that's upstream, the social determinants of health. But also there's some fascinating spillover research that has identified the point of origins and the root causes that are biopsychosocial in nature to these epidemics, which is so important that we get a range of expertise talking about this. And if any final words, please take the opportunity, but I'd just like to thank you, Dr. Gurley, Tamika, Dr. Hawkins, for a really, really wonderful health equity research seminar today.
Thank you for having me, Sean.
Thanks so much.
Thank you so much. It's an honor to meet you all. All right, so Rachel, let's move on to the just the summary here. For questions, comments, concerns, requests to present at a future seminar, you can contact me directly. There's my email. And also, if you could all take a brief survey regarding today's presentation, it will be appreciated. There will be an email going out to fill out that evaluation. We do read those evaluations and they're very helpful. And there's also a site after the close out of the window and the link to that evaluation. So maybe Rachel, you could talk about that. Our seminar series will break for the holiday break, but we will return on February 21st at the same time. And the recording of this event will be distributed in a few days on our YouTube channel. Thank you all and have a great rest of your week. Rachel, do you want to?
Oh, no, thank you so much. And yes, as Dr. David said, there will be a follow-up email with all of this information, a copy of the presentation for you to view. Everything will be uploaded to YouTube. So everything will be available for you in case you missed anything, and also to retrieve your CME credit. All right. So thank you so much, everyone.
Thank you very much.
Thank you.
Have a good rest of the week. Bye-bye. Thank you, Dr. Gurley. Thank you, Tamika.
Thanks. Nice